Welcome to the Irish Practice Nurses Association online education series for general practice nurses. My name is Teresa Lowry-Lenin. I'm a member of the Carlow branch of the IPNA, and today we will be discussing urinary tract infections. Urinary tract infection, or UTI, is the collective term used to describe infections involving any part of the urinary tract, which includes the kidneys, ureters, bladder, and the urethra. Infections of the bladder, which is cystitis, and the urethra, which is urethritis, are known as lower UTIs. Infections of the kidneys, which is pyelonephritis, or the ureters, are classed as upper UTIs. The urinary tract is the second most common site of bacterial infection and a significant cause of morbidity, both in terms of the number of people affected and potential complications. UTIs are classified as complicated or uncomplicated. An infection is considered complicated if it affects pregnant women, children, men, and the elderly, or if it affects the upper urinary tract. Uncomplicated urinary tract infections involve the lower urinary tract and cause acute dysuria and frequency in otherwise healthy and non-pregnant women. The urinary tract is a common source of infection in pediatrics and is the most common bacterial infection in children under 2 years of age, both in the community and hospital settings. Approximately 8% of girls and 2% of boys will have a symptomatic UTI in childhood. During the first 6 months of life, however, UTIs are more common in boys than girls, and especially in uncircumcised males. E. coli is the causative organism in 90% of cases, and 30% of children with UTIs have vesicouretic reflux. An accurate diagnosis via urine culture is essential. The incidence of UTIs in adult males under the age of 50 years is low. Up to 40% of women develop a UTI at some point in their life, compared to 12% of men. In men, cystitis is often associated with infection and inflammation of the prostate gland, known as prostatitis. Anatomically, the female urethra is shorter and located closer to the anus than in males, which makes it easier for bacteria to reach the female urethra and bladder. Adult women are 30 times more likely than men to develop a UTI, with almost half experiencing at least one episode during their lifetime, and 1 in 3 women experiencing their first episode by the age of 24. UTIs are common in sexually active young women. Sex can irritate and weaken the urethra, making it easier for bacteria to enter. Certain contraceptives can increase a woman's risk of developing UTIs. These include the diaphragm and spermicide-coated condoms. Keeping hydrated, urinating as soon as possible after sex, and avoiding synthetic underwear can help prevent UTIs in females. Other susceptible adults include the elderly and patients requiring urethral catheterization. Presentation in the elderly may be vague, with incontinence, change in mental status, or fatigue as the only symptoms, while some present with sepsis as the first symptoms. Diagnosis can be complicated by the fact that many elderly people have pre-existing incontinence or dementia. Other risk factors for developing UTIs include conditions that prevent fully emptying the bladder, kidney stones, a weakened immune system, chemotherapy, diabetes, and an enlarged prostate gland in males. Symptoms of a lower urinary tract infection include dysuria, frequency, and the urge to urinate despite having an empty bladder. Symptoms may also include cloudy and unpleasant smelling urine, hematuria, abdominal pain, pelvic tenderness, back pain, and a general sense of feeling unwell. Symptoms of a kidney infection or an upper urinary tract infection include fever of 38 degrees Celsius or above, shivering, nausea, vomiting, diarrhea, and flank pain. In addition, frequency, dysuria, urgency, and hematuria may also be present because the infection can spread from the kidneys to the lower urinary tract. The presence of bacteria in urine does not necessarily depict a UTI. Many people, especially the elderly, have bacteria in their urine without having any ill effects. This is known as asymptomatic bacteriuria. E. coli bacteria from the gut is the cause of 80 to 85% of community-acquired urinary tract infections, with Staphylococcus saprophyticus being the cause in 5 to 10% of cases. Occasionally, they may be caused by viral or fungal infections. Healthcare-associated urinary tract infections, mostly related to urinary catheterization, involve a much broader range of pathogens, and these include E. coli, Klebsiella, Pseudomonas, Candida albicans, and Enterococcus. Urinary tract infections due to Staphylococcus aureus typically occur secondary to blood-borne infections. Chlamydia trachomatis, a Mycoplasma genitalium, can infect the urethra, but not the bladder. These infections are usually classified as a urethritis rather than a urinary tract infection. Let's now look at the diagnosis involved in urinary tract infections. Urinalysis reagent strips are the most frequently used instrument for diagnostic testing if there is clinical evidence that a patient has a UTI. A high number of leukocytes in the urine points to the presence of white blood cells, indicating inflammation or infection along the urinary tract, often in the bladder or kidney. The presence of nitrates in the urine is highly specific to certain bacterial infections, but nitrates do not occur with all types of bacteria. E. coli bacteria are most commonly associated with nitrates in the urine. An infection may occur in the presence of leukocytes with no nitrates. However, leukocytes in the urine without nitrates can also lead to a false positive result that points to a bacterial infection when there is none. Negative nitrate and negative leukocyte has a 95% negative predictive value. A positive nitrate test is more indicative than a positive leukocyte test, although the presence of both increases the possibility of a urinary tract infection diagnosis. For most women who have the typical symptoms of a lower urinary tract infection, further testing is not usually required to confirm the diagnosis. The following are circumstances where laboratory testing is recommended. All cases of UTIs in men. UTIs are uncommon in men, so it is important to rule out other possible causes of the symptoms. Cases of a suspected upper urinary tract infection. These infections have a higher risk of complications, so a careful assessment of the state of the urinary tract needs to be made. UTIs that occur in pregnant women due to the higher risk of developing complications. In cases where a person has blood in their urine, this could be a symptom of bladder cancer, so it is important to outrule that diagnosis. Where a person has a risk factor that makes them more vulnerable to developing serious complications, such as having a weakened immune system. Other diagnostic tests required may include ultrasound, CT scan, magnetic resonance imaging, or cystoscopy. Let's now look at the treatment for adult uncomplicated urinary tract infections. Choice of empirical therapy should be governed by local resistance rates, as patterns vary significantly. For first presentations with low risk of resistant organisms in uncomplicated urinary tract infections, narrow-spectrum antibiotics such as fosfomycin, nitrofurantoin, or trimethoprim should be considered. For uncomplicated urinary tract infections, quinolone should be reserved for resistant infections with limited options and confirmed by culture and sensitivity. The use of fosfomycin, however, should be limited for certain usage. Community multi-resistant E. coli with extended spectrum bactylamase enzymes known as ESBL are increasing, so culture should be carried out in all treatment failures. ESBLs are multi-resistant but often remain sensitive to nitrofurantoin and fosfomycin. There is less relapse with trimethoprim than cephalosporins. To preserve the efficacy of fosfomycin, its use should be limited to uncomplicated urinary tract infections in women or specific situations on advice of a specialist. Fosfomycin is not recommended for use in treatment of urinary tract infections in patients over 65 years of age in long-term care facilities, except in specific situations on advice of an infection specialist. Fosfomycin should be avoided in the elderly and in patients with renal impairment due to diminished urinary concentrations. Recommendations for use of fosfomycin in pregnancy remain under review pending further evidence and safety data. In the treatment of acute pyelonephritis, an MSU must be sent for culture. In acute pyelonephritis, 7 days of treatment with ciprofloxacin is considered as effective a treatment as 14 days of trimethoprim, otherwise known as cotrimoxazole. If there is no response within 24 hours, the patient should be admitted to hospital. Children less than 3 months old who present with urinary tract infections will be referred to a specialist and treated in hospital. Children over 3 months old with a urinary tract infection, where there is a risk of serious complications, will also be referred to hospital for treatment. For children over 3 years of age with a low risk of complication, the infection can be treated at home using oral antibiotics and paracetamol. For lower urinary tract infections, a 3-day course of antibiotics with cephalexin, nitrofurantoin, or trimethoprim is usually commenced, and for upper urinary tract infections, a 7-day course of cephalexin or coamoxiclav is usually recommended. Positive nitrates must be present in the urine to commence antibiotic treatment. So let's take a look at the treatment of recurrent UTIs in women. If more than 3 urinary tract infections occur per year, continuous or postcoital prophylaxis with antibiotics can be effective in women. Both are associated with antibiotic side effects. There is no evidence, though, that standby antibiotics are effective. The treatment is usually nitrofurantoin, 50 mg, stat postcoital, or trimethoprim, 100 mg, once daily, taken at night. For urinary tract infections in pregnancy, an MSU must be sent for cultures and any empirical treatment reviewed when results of the MSU culture and susceptibility are available. Amoxicillin resistance is common and should be used only if susceptibility data is available. Nitrofurantoin should be avoided after 36 weeks gestation due to the risk of neonatal hemolysis. Fosfomycin use in pregnancy remains under review pending further evidence and safety data. So the treatment here usually is nitrofurantoin 50 to 100 mg 4 times a day for 7 days, or amoxicillin, if it's known to be susceptible, 500 milligrams 3 times a day for 7 days. Or the second line of treatment could be cephalexin, 500 milligrams twice a day for 7 days. Let's now consider the diagnosis and management of urinary tract infections in long-term care residents over 65 years of age. A positive urinalysis reagent strip result in an asymptomatic patient should not be treated. Residents in long-term care facilities have high rates of positive dipstick urinalysis results without infection necessarily being present. Antibiotic therapy in these cases does not reduce mortality or prevent symptomatic episodes. Rather, it increases side effects and leads to antibiotic resistance. Empiric treatment may be considered in a symptomatic patient with a positive dipstick. A urine sample should be sent to the microbiology lab for culture and antimicrobial susceptibility testing in these cases. Symptoms suggestive of a UTI include dysuria, frequency, urgency, new onset incontinence, fever over 38 degrees Celsius, suprapubic tenderness, and hematuria. Diagnosis of UTIs in long-term care residents over 65 years should be based on a full clinical assessment. In patients with a urinary catheter, loin pain, and fever greater than 38 degrees Celsius are, however, significant indicators of a urinary tract infection. Empiric antibiotic therapy should only be considered in symptomatic patients pending urine culture results. Choice of empirical therapy should be guided by local resistance rates and treatment modified according to culture results when available. The empirical treatment of UTI in long-term care residents over 65 years for those with an uncomplicated UTI with no fever or flank pain, maybe their first presentation or at low risk of resistant organism, trimethoprim 200 milligrams twice a day or nitrofurantoin 50 milligrams 4 times a day for 7 days may be used, but should be avoided in renal impairment. Or the use of cephalexin 500 milligrams twice a day or coamoxiclav 625 milligrams 3 times a day may also be considered based on local resistance rates. For the same empirical treatment of UTIs in long-term care residents over 65 years of age, if it's an acute pyelonephritis, coamoxiclav 625 milligrams 3 times a day for 14 days, or ciprofloxacin 500 milligrams twice a day for 7 days would be considered, and if there's no response within 24 hours, hospital referral should be considered. For the empirical treatment of urinary tract infection in residents with a urinary catheter, duration of therapy is usually 7 days. Delayed response, regardless of whether the patient remains catheterized or not, is 10 to 14 days. If an indwelling catheter has been in place for more than 2 weeks at the onset of a urinary tract infection and is still indicated, the catheter should be replaced. Antibiotic prophylaxis is not recommended for the prevention of symptomatic urinary tract infection in catheterized patients, or for urinary catheter changes unless there is a definite history of symptomatic urinary tract infections due to catheter change. Antimicrobial prophylaxis may, however, be considered in patients for whom urinary tract infections are of such frequency or severity that they chronically impinge on function and well-being. And the treatments here, so the first presentation or low risk of resistant organisms, trimethoprim 200 milligrams twice a day or nitrofurantoin 50 to 100 milligrams 4 times a day. Again, avoided if there's any renal impairment. If there has been previous resistance to or risk of trimethoprim or nitrofurantoin resistance, the treatment would be with cephalexin 500 milligrams twice a day or coamoxiclav 625 milligrams 3 times a day, again based on local resistance rates. Although urinary tract infections are often considered to be easily managed infections, they remain an economic burden for the healthcare system. In 2014, the annual primary care costs were approximately €19.2 million compared to the low annual cost of urinary tract infections in secondary care at approximately €155,000. These costs were estimated on the basis of GP consultation costs, antibiotic costs, lab costs, and secondary inpatient and outpatient costs. Suspected urinary tract infections are a common reason to attend primary care services in Ireland. From the health service perspective, the overall economic cost of urinary tract infections is mainly driven by primary care costs with comparatively low secondary care costs. The increasing prevalence of antibiotic resistance presents a major challenge to the clinical management of urinary tract infections. Although in most situations antibiotics are required, inappropriate treatment contributes to the growing problem of antibiotic resistance. Appropriate empirical treatment of urinary tract infections is important for successful treatment and prevention of complications. However, with the increasing prevalence of antibiotic-resistant urinary pathogens, the selection of an appropriate empirical agent is increasingly difficult. Resistance to cotrimoxazole and fluoroquinolones is increasing, as is the prevalence of extended-spectrum beta-lactamase-producing Enterobacteriaceae and multi-drug-resistant Pseudomonas aeruginosa. The problem is particularly prominent in the hospital setting, where urinary tract infections can present as severe infections and MDR organisms are frequent. Understanding the key criteria for antibiotic selection, pathology of UTI and therapeutic profile of commonly prescribed agents is vital for practitioners to ensure rational, safe and cost-effective treatment. Judicious use of antibiotics in common clinical situations is crucial for minimizing antibiotic resistance and the effective treatment of patients. This is a list of the references that were used in the production of this presentation. I hope you enjoyed this presentation on urinary tract infections, which is part of an online education series for general practice nurses produced by the Irish Practice Nurses Association. My name is Teresa Lowry-Lanin. I'm a member of the Carlow branch of the IPNA. Thank you.